This is video number 3 for the pain lecture. Sorry, the last one cut me off when I was talking about the pain scale in every facility having a different number. The hospital I worked at in Maryland had a 0 to 5 scale. So 0 was no pain, 5 was the worst possible pain. So you would have anywhere in between. I like a 0 to 10 pain scale because I think that it there's more definition in it. The more numbers, the more choices, and I think you get a more detailed view of pain, but that's just me personally. So let's talk about culture a little bit. You need to accept the cultural difference without stereotyping the person. Cultural influence have a huge effect on how a patient feels about pain. And you have to remember when you're thinking about culture, it's not just race. It's also religion, gender, age. Again, in our neck of the woods, the plain community is huge, and usually they are traditionally Amish, but that doesn't mean they all are. So we have to make sure that we accept a cultural situation for what it is, which is far bigger than someone's race or ethnicity. Also, past experience has a huge barrier on pain. I can speak to this personally. I had knee surgery, gosh, I'm trying to think, 2011. And it was supposed to be an in and out meniscus repair of my right knee. And when they got in there, my meniscus was not torn, it was crushed, so they had to rebuild it. So my 20-minute surgery turned into a 3-hour surgery, and instead of ambulating out of the building, I was non-weight bearing for about 6 weeks, and it took a year and a half to not hurt. So I have this image of pain that really affected my life. Now, I worked through it. I never stopped working, actually. I shouldn't say that. Had my surgery in December, went back to work right after Christmas. I taught, but I taught on a chair with my leg elevated. My students were very tolerant. And then I started on the clinical floor again in early February. My knee hurt for a year and a half. And I can remember a day when I thought, you know what? I haven't had any pain today. I got myself off narcotics really quick, actually within about 3 days after surgery, because um, I I just couldn't take all the things that were happening because of the narcotics. I'm just not a good drug using person, not addiction stuff, but I just don't find them appealing at all. I tried a lot of other things that worked pretty well, including physical therapy, but I am very afraid of hurting my knee again. And so there's just things that I won't do because of the inconvenience of being injured, but also the past experience was so incredibly unpleasant that I don't ever want to deal with that again. Old people, they lose neurons. Their spinal cord becomes injured. Their spinal column compresses. Um, they they'll hold back on their pain because they don't want to have to go to the home or even go to the hospital. So they might not tell anyone about pain until it's really bad. And then sometimes we find things like cancer and other issues that may have been treated had they spoken up about their pain. Um, Along with asking a patient about their pain, you must, like I was saying earlier, you must be looking at all of the psychosocial issues, their facial expressions. Are they aggressive? Are they impatient? Um, how has it affected their activities of daily living? Is their body not moving how it should be? Are they irritable, confused? Is it affecting how they breathe? Are they sweating? All of those things are just as important as the number 10 pain scale. Pain management extends beyond pain relief, and this is so important because sometimes pain can't be relieved. Again, a year and a half of pain, but I couldn't stop working and I couldn't stop living. So I had to find ways to go through and be productive. And again, mine was a traumatic injury, so that was pretty easy. I just had to figure out a way to get myself around on my crutches and sit in situations where I normally stood and things like that. So it can be done. And you have to work with the patient to make sure that you come up with creative things for them to do. Make sure that your patient is an active participant in their care. You can't make the decisions for them. They have to be able to make them on their own. No matter what the clinical setting is, they have a voice, and you have to involve the patient as well as their family if it's appropriate. Believe whatever the patient tells you and ask them how they have dealt with the pain in the past. Teach them about pain and pain relief measures. Do not minimize any experience that they've had because it's real to them. And very important. Some people with chronic pain go to support groups. You can teach the patient. I think that this is so overlooked. We forget about non-pharmacological things like teaching a patient just how to deep breathe and relax. That is just so important. Heat, ice, a TENS unit, massage, so many things can be done to help the patient. And then we have to explain what each option is. Medications go far beyond pills. There's IV medications, there's PCA pumps. Cutaneous stimulation has to do with decreasing nerve impulses, as do these. Massage has to do with making the brain think different things are happening than what's really happening. So there's all different kinds of things that we can do, and all of the different ideas need to be shared with the patient. Here's some pictures. Acupuncture. We're living in a more holistic age now, and especially in this area, there are so many therapies that are available that aren't narcotics, that we really need to help the patient explore. So I think this is a really good acronym also. And this goes into old carts is explaining the pain itself. And then ABCDE is more about how we're handling and how we're dealing with their pain. So A is ask about and assess the pain. B is believe the patient. C, choose the appropriate pain control options. D, deliver interventions in a timely fashion. So you can't get busy when someone's saying they have number 10 pain, man. You got to medicate them. And then empower and enable the patients and their families to ask for help and to know their signs and symptoms. So I think this is really, along with old carts, a really good acronym to remember. Don't forget to reassess your client very frequently. Make yourself available to them, and of course document anything you do. If you work in a long-term care facility, Medicare now requires, and so does the state, that before you give any kind of pain medication, you have to explore a non-pharmacological intervention, whether that be moving the patient, turning lights off, giving them extra pillows, giving them an ice pack, distraction, quiet, massage. You have to document that you've done a non-pharmacological treatment first before you can give any kind of medication. And I think that's great because it really helps the patient not have to go right away to drugs, and it gives the nurse some ideas of what to do. And remember that pain is the 5th vital sign. So, you do blood pressure, you do pulse, you do heart rate, or you do blood pressure, pulse, respirations, temperature, and then pain. And all of these things, of course, they're vital signs because they are vital. Your body has endorphins, and endorphins are a natural pain reliever. They attach to the opiate receptors in the brain. Guided imagery, acupuncture, laughter, exercise, chocolates all increase the use of endorphins. So we need to really access those because they're natural and they're already in our bodies. If we're going to use pain management, we also want to make sure that we are medicating before the pain gets out of control. And again, like we said before, if someone is taking pain medicine because of a actual pain that's there right then, the risk of addiction is actually quite minimal. It's when people take pain medications because the pain's not really that bad, but they like how the pain medication made them feel, then we have a problem. Here are our options: non-opioids, opioid analgesics, other analgesics, and cancer therapies. And then there's non-pharmacological treatments and interventions, which we already talked about. Medication, of course, traditionally is the medication that's first choice, but I think those days are coming to an end, where we're going to start to see some other kinds of therapies take precedence over drugs. Here is kind of the step for cancer or for pain management. Um, this is actually used for cancer patients, but it can be used for any patient with any kind of pain. So the first step is non-opioid medications. So NSAIDs, Tylenol, anything like that. And then you go up the step because the pain's continuing. So then they're going to use a very low level opioid, Percocet. Used to be back in the day Darvocet. They don't do Darvocet anymore. Too bad, because that was a great drug. And then on up to strong opioids, fentanyl, morphine, those kind of things. And whatever we have to do, we're going to keep climbing those steps so that cancer patient is free from pain. Non-opioid analgesics, aspirin, salicylates, NSAIDs, Tylenol. You probably want, I know you want to know about these medications, so do a med template, like the ATI templates or the med sheet I gave you for aspirin. Do one for NSAIDs, like you can either do the class or you could do ibuprofen. There's some more listed on here, but I would certainly know non-opioid drugs and the drugs that are mentioned in these slides. Aspirin is really not used for pain management very often because it has so many other side effects. First of all, the bleeding side effect. We, of course, give cardiac patients aspirin to keep their platelets low so that their blood is more slippery and less chance of clotting. If aspirin was put on the market now, it would probably be a controlled drug because there are so many dangers of it. And actually, no one really knows why it relieves pain. Same with Tylenol. They just don't know what it does. But it works. Salicylates can be used for pain. Very rarely are. But they are used sometimes for rheumatoid arthritis when nothing else is working. But again, then you have to really educate the patient on the bleeding side effects. Here's some of the side effects, and here's some examples beyond aspirin. Dolobid you'll see sometimes in a muscular injury. They'll use that. They must take them with food because they cause GI irritation. Next step up is NSAIDs, ibuprofen. You're all familiar with that. It's an anti-inflammatory, so that's how it relieves pain by reducing the pressure in the cells. It's obviously a pretty good drug. These slides, I'm not going to go through them. You can go through them on your own for what they're used for, what the side effects are, and here's some examples of obviously Advil, ibuprofen, but then there's phenoprofen, there's naproxen, and indomethacin. And indomethacin is also used a lot for musculoskeletal injuries. And then there's Tylenol. You got to watch out, of course, with all these drugs for allergies. So some people can take ibuprofen or NSAIDs, but they can't take Tylenol. I have one daughter who is allergic to ibuprofen, which is an NSAID, and another daughter who is allergic to Toradol, which is also an NSAID. The one who's allergic to ibuprofen can take Toradol. The one who's allergic to Toradol can take ibuprofen. So it's really a bizarre situation. However, in a hospital setting, I ask them to not give either of them Toradol because the reaction can be so bad. The big thing you want to know with Tylenol, acetaminophen, is the hepatotoxicity, which is liver problems. You cannot take more than 3,000 milligrams of Tylenol in 24 hours. Some texts will say 4,000, so somewhere between 3 and 4. because it can cause liver failure. And I'll try